Hi everyone, my name is Jewel Kanja. I am a current PGY1 pharmacy resident at Henry Ford Hospital in Detroit. Today I'll be going over your pre-work for your TBL coming up on Tuesday, which will be on pregnancy and chronic illness, specifically asthma and hypertension. Before we start, I want to highlight that the purple font in this handout are areas I want you to pay special attention to when preparing for your TBL and the exam. So to start, let's go over the learning objectives. So by the end of this pre-work and TBL, you should be able to apply a structural approach to pharmaceutical care for women and trans men wishing to conceive or who are pregnant. Also explain the impact of pregnancy on physiology and pathophysiology related to asthma and hypertension. Lastly, develop therapeutic plans to control asthma and hypertension prior to and during pregnancy and breastfeeding that improve maternal and fetal health, pregnancy outcomes, and infant well-being. So before getting to asthma or hypertension specifically, it's important that we highlight the overall goals of therapy in pregnant patients. So we want to be able to ensure good health and care before, during, and after the pregnancy. As pharmacists, it's important that we optimize the medications for efficacy and safety for both the mom or trans man, the fetus, and the pregnancy itself. We can also go over the pharmaceutical care approach to delivering healthy babies. So with that, understanding the different pregnancy phases and where we may need to intervene differently. So we have our pre-planning stage, our first trimester, second to third trimester, delivery, and then breastfeeding. So now getting to asthma. So when we think about pregnancy, it is important that we think about what is really happening to the body and how that might alter chronic illness such as asthma. So first, there are changes in progesterone and estrogen that will alter the patient's respiratory rate and sensitivity to carbon dioxide, which is highlighted below. To note, there is a 30 to 50% increase in minute ventilation by late pregnancy, and this is regardless of asthma status. Additionally, so we can anticipate that the diaphragm of the mother or trans man would actually elevate by 4 to 5 centimeters just by the physiology of being pregnant. From this, we can expect a decrease in the functional residual capacity. So moving on to epidemiology. So asthma actually develops in 3 to 8% of pregnancies. When looking at our patients with asthma, once they get pregnant, there's data to support the rule of thirds. That being that if a patient is pregnant, 1/3 of them will experience improvement in their asthma, 1/3 will have no change, and 1/3 will actually experience deterioration in their asthma. We also want to acknowledge the risk of exacerbations in pregnancy. So as the patients progress in their pregnancy, there is an increased risk of exacerbations. So we can see that most of the exacerbations are going to be seen in the second and third trimesters, but mostly in the second trimester. We also need to consider things that typically will happen in pregnancy that can also play a role in either worsening or improving asthma. So things that may worsen asthma related to pregnancy would be increased stress, gastric esophageal reflux disease or GERD, infections, and rhinitis. Things that could improve asthma would be estrogen and then the descent of the fetus. So this table here highlights the outcomes to the mother, the pregnancy itself, and the fetus. I will let you guys read through that table. Now we can move on to pregnancy pre-planning. So here's highlights a lot of things that the pharmacist, being us, can play a part of in patients' asthma management. So it's important to acknowledge to the patient that you do not want to stop your medications before pregnancy. We want to hopefully switch to appropriate medications that can be used in pregnancy. And of course, correct inhaler use and suboptimal adherence. Additionally, our non-pharmacological non-pharmacological strategies are important to highlight, as with all of our patients. As mentioned, and with all disease states, patient education can go a long way. Asthma is no exception, especially in pregnancy. So the Canadian Respiratory Journal published the following findings of patient understanding or adherence to the following asthma topics. So just to highlight a few, 65% reported poor asthma control, 64% reported poor inhaler technique. Only 38% knew the difference between a reliever and a controller. So these are all interventions that we can make when looking at our patients. Also important to acknowledge our asthma goals in pregnancy. So when it comes to our goals, we want the patient to be able to maintain normal or near normal PFTs, maintain normal oxygen saturation, maintain normal FeNO scores, and to control their symptoms. So I will pause here before we get into the medications and the management. We'll pick up there in the next video. See you then.